Hello, and welcome to Cottage Health's Meet the Doctor Cardiology webinar. I'm Christina Cortez, the Public Relations Manager for Cottage Health. Before we get started, I'd like to review a few housekeeping items to optimize your experience. At the conclusion of this webinar, we will host a brief question and answer session. Please be sure to use the Q&A button to ask Dr. Casey a question. The webinar is also being recorded and it will be emailed to you later on. So it's now my pleasure to introduce Dr. Kevin Casey. Dr. Casey moved to Santa Barbara in 2016 after serving as a physician in the United States Navy. Over the past 5 years, Dr. Casey has become an active member of the medical community and larger Santa Barbara region. He was president of the Central Coast Medical Association in 2020 and currently serves as the chair of the Department of Surgery at Santa Barbara Cottage Hospital. Dr. Casey continues to participate in academic medicine, publishing multiple journal articles in peer-reviewed publications. He has been the lead or co-investigator in over 30 peer-reviewed articles on topics such as peripheral arterial disease, carotid artery disease, abdominal aortic aneurysms, and dialysis access. He is the only surgeon on the Central Coast who routinely performs first rib resections for thoracic outlet syndrome and recently published a manuscript on these outcomes in the Annals of Vascular Surgery. Dr. Casey believes in the phrase cura personalis, or care for the whole person. He treats patients as people, not just vascular diseases or medical conditions. So now, the moment we've all been waiting for, please join me in welcoming Dr. Casey.
Great. Thank you, Christina, and thank you to Cottage Health for allowing me to give what I think is an interesting talk, and I hope that everybody online does as well. I know I have patients that I've treated. I have patients who I'm setting up for possibly surgery, and then others, of course, who are just interested in learning more. So I hope that you all find this interesting and an enjoyable hour. So Plumbing 101, the newest technologies in treating aortic aneurysms. I put that title because I often get asked, well, what does a vascular surgeon do? And I pretty much tell people that I'm a plumber for the body. And so when I started thinking about it and looking into it, unfortunately, the first famous plumber that I thought about was Schneider from a really terrible 1980s sitcom called One Day at a Time. In doing some more research, I realized that Mario and Luigi are actually plumbers before they started saving princesses and became basically international stars. And then finally, I'm in good company with Rosie the Riveter from The Greatest Generation, one of our most well-known famous plumbers. So I have nothing to disclose for this talk, and so I just wanted to give a little bit of brief history about my background. When I finished my residency, I went in and became a general surgeon on the USS Ronald Reagan, largest aircraft carrier in the world. And I was there for 1 year before I went on to my vascular surgery fellowship, and then came back into the Navy for 5 years in San Diego, where I was deployed as the vascular and trauma surgeon in Afghanistan, and then was also on the Mercy, which was the medical ship, where I was the advanced lead for the Surgical Pacific Partnership in 2015. I separated in 2016 and have been really loved my time here at Cottage and in the Santa Barbara community over the last 7 years. So why did I choose vascular surgery? Well, I think I'm very passionate about vascular surgery. I think it's really an amazing specialty. And because I really think that I am a patient's advocate, there's a large primary care component. So I talk to patients about smoking cessation and about controlling blood pressure and their hemoglobin A1Cs. We have a long-term follow-up with our patient population. And so today, for instance, in clinic, I saw patients that I treated for 6 or 7 years ago, and that is very, very important to me. As a vascular surgeon, we treat everything outside of the heart, from the neck down to the feet. There's always an interesting, extensive variety of surgical procedures. And vascular surgery, I believe, is on the forefront of technological advancements, which is a large part of what I'm talking about today. So an aneurysm is nothing more than a fancy way of saying a dilation or a bulge in the blood vessel. It originally came from the Greek, which means to widen out. Any blood vessel can become aneurysmal, and we define an aneurysm as any blood vessel that's 1.5 times or 50% larger than its normal diameter. The problem here is that just like a balloon, if it becomes large enough, if an aneurysm becomes large enough, then it may pop or burst. We call that rupturing, and rupture carries with it a large morbidity and mortality. Studies show that if an abdominal aortic aneurysm ruptures, 1/3 of the patients never make it to the hospital, 1/3 of the patients never make it out of the hospital. So, and those that do can often have a long, prolonged recovery. So just to give a little bit of brief anatomy of the aorta. So the aorta, just like everything in medicine, we try to define it into different anatomic locations. And so you've got the ascending aorta, which comes right out of the heart. That is one area that we don't actually treat, and the reason is because that often requires going on to bypass and is often associated with cardiac surgery. And so our CT surgeons usually treat that. But the arch here, where the carotids originate from, and the descending aorta, and then of course the abdominal aorta is where we talk a lot and treat very frequently. The abdominal aorta, right behind the belly button, divides into the iliac arteries, which then feed the lower extremities. So the aorta, just for future reference, because we'll be talking about this, sits right on the spine, well behind the intestines. So even though we're talking about it behind the belly button, it's actually way behind in the back. So aneurysms can occur in any blood vessel in the entire body. The most common location, as you can see on this pie chart on the right, is in the abdominal aorta, and that's where 58% of aneurysms occur. However, the remainder, smaller number, can occur in the ascending or transverse arch, the descending arch, which we'll talk about too. The femoral arteries, studies show that up to 50% of patients with an abdominal aortic aneurysm have 15% either have a femoral or a popliteal artery aneurysm as well. And we don't worry about rupture with femoral or popliteal artery aneurysms as much as we do what is called embolization or clot forming within the aneurysms themselves. Even the arm vessels can become aneurysmal, which is something that we looked at, an interesting case that was in San Diego for a patient who developed an aneurysm which was compressing her median nerve. And you can see here just how dilated and large this blood vessel has grown. And so this required fixing to prevent the patient from having worsening numbness in her hand. And so, as I said, a rupture is a surgical emergency. And so on the screen left here, you can see that our normal aorta has normal laminar, what we call laminar flow, with good, consistent flow through the entire vessel. But for different reasons, as that aorta becomes more dilated or widens out, it increases the risk of rupture from a weakening in the vessel wall. And so here's a CT scan, just to give everybody a reference. A CT scan does serial cuts through the entire body. And so up here is your abdominal wall, down here is your spine. You can see here are the kidneys, and I'm going to start scrolling in just a second. And here is the vessel that we're looking at, your aorta. And you can see the relationship to the spine here. And as I scroll down, you can see this contrast right here is flow in the aorta. Here's an aneurysm of the aorta. And here is where you can see flow outside of the vessel wall. And so this is where the aneurysm has actually ruptured in this patient. And so I often get asked by patients, well, what are the symptoms? What can I expect? from my if I have an abdominal aortic aneurysm. Unfortunately, the large majority of patients don't know that they have a AAA. And the reason for that is because it does sit way deep in the retroperitoneum on the spine. Very rarely patients can complain of back pain, which usually is a sign of an impending rupture. However, most patients don't really know that they have one until they actually rupture. And that's why screening, get to in just a minute, is so incredibly important. The risk factors, the number one risk factor by far is smoking cigarettes. And that includes, unfortunately, just even a history of smoking. 6 times, smoking is 6 times, is a 6-time higher risk factor for both aneurysm growth and rupture than all these other risk factors combined. And so age, as we age, increases the risk of a AAA forming. It's more common in males than females. We know that there's a family history association, and hypertension and high cholesterol are other less common risk factors. And then there's a lot of research going on looking at infection. We also know that connective tissue disorders like Ehlers-Danlos or Marfan's lead to aneurysms throughout the body, and trauma can usually present with a delayed aneurysm. And so when we look at the prevalence of abdominal aortic aneurysms in men, this was just one study that looked. You can see the 2 graphs here. The gray graph shows people who have smoked at any point in their life, and those in red are people that have never smoked. So you can see, of course, these are more common as we age, but the really striking difference here is the tobacco use between those that have developed aneurysms. So why do they form? Well, it's thought to be multifactorial, and there's a lot of research going on, and some of which we're still really learning. So elastin and collagen are the connective tissues that are proteins that are found in the vessel wall. And so both of these are degraded in patients with AAAs. And this is smoking is absolutely found to break down collagen and elastin, is why there is such a significant relationship between smoking and AAA development. Inflammation, whether is also present and can be an important role in the weakening of the vessel wall. We do know that genetics plays a role, but the exact gene or multifactorial genes is not exactly known. And so, of course, what we care about here is rupture and the risk of a rupture. And I like this chart because it's very straightforward, because we can talk very clearly about why we operate on people and at what sizes. So you can see when you very small aneurysms, less than 4, even really less than 4.9 centimeters, the annual risk of rupture is less than 2%. However, once you get to be 5 to 6 centimeters, the annual risk of rupture increases to 5 to 15%, and dramatically increases from there. Most people, you'll notice, never get to 8 centimeters because they usually will have either been fixed or ruptured before then. I've only operated on an 8 or larger AAA probably about 5 times in my life, and most of those were taken to the operating room within 48 hours, because you just don't know you don't have a crystal ball on who that patient is going to be. However, based, again, on very, very good studies, we do know that the risk of a complication from surgery is about 2 to 4%, and the risk of mortality it should be less than 2%. And so this is very clearly why we decide to operate on the 5 patients once they get to 5 to 5.5 centimeters. And so a common question, and one that I asked earlier in my training as well, but a common question from patients is, well, wouldn't it just make sense that you operate on smaller AAAs then? Wouldn't it? I mean, you don't want to ever get to be that size. But there were 2 really, really good studies from the 1980s and 90s, one from the UK and one from the United States. And what they looked at just that question. And so what this is called a Kaplan-Meier analysis. And you can see here on the time from randomization is on the axis here, and you've got your overall survival. And so when you've got two curves like this, one of these is early surgery, and the other is those patients that didn't have surgery for small aneurysms. And we're looking at the overall survival. And you can see that these two curves over 12 years are pretty much exactly the same, suggesting that there was no benefit over one or the other. And the reason for that is that if you have a small aneurysm, for very often times, it never gets to be that 5 to 5.5 centimeters, and that's our goal. And there was really no benefit over early surgery. And the reason for that is because we have gotten better with medical management over the years. And so the first goal of any aneurysm less than 5 to 5.5 centimeters is to prevent that growth. And that is by optimizing medical care. So if you smoke, you absolutely need to stop immediately. And again, I know I'm probably harping on that, but I can't emphasize that enough. There have been two medications that have been shown with very good data to stabilize the growth of aneurysms. One is a daily aspirin, and the other is a statin. We commonly call these statins. You might have know them as Lipitor, Crestor, atorvastatin, simvastatin. These are all different names, both generic and formulary. Tight control of blood pressure for many reasons, but including that hypertension does slightly increase the risk of aneurysm growth, and of course, regular surveillance. And as I always tell my patients, you should not think of this as a ticking time bomb. You should be out living your life with routine screening and risk factor modification. You should be able to do everything that you want to do. And so for when we do talk about screening, those patients who do benefit from early screening are those patients. A one-time ultrasound is recommended, and this is from the Society for Vascular Surgery, in all men at or older than 65 years. Screening for men as early as 55 is appropriate for those with a family history of AAA. And then one-time screening ultrasound for AAA is recommended for all women at or older than 65 years with a family history of AAA or who have smoked. And so most patients at age 65, I think there's a Welcome to Medicare program where they will pay for a one-time ultrasound for most patients. And if at that point you don't have any signs of an aneurysm, the chance of you ever developing one in your lifetime is almost nil because it is such a slow process. And so screening is our best screening technique is an ultrasound. It's very reliable, it's very sensitive, and it has many other advantages over invasive imaging. It's non-invasive, it is very cheap, and it's easily reproducible. The one limitation to ultrasounds in general, and of course vascular is no different than this, is that it's limited by the skill of the technician. Body habitus, especially for the aorta where it sits deep behind the abdomen, can also be a limitation in a very few patients. And so once an abdominal aortic aneurysm or AAA grows to 5 to 5.5 centimeters, and the difference there is that usually we operate on women closer to 5 centimeters because they do have smaller vessels in general, and so the benefit is gained from 5 centimeters. Once it gets to be 5.4 or 5.5 in a man, we're offering surgery. Other people that are recommended to undergo surgery are those who have demonstrated rapid growth, which is usually considered greater than a half a centimeter in a 12-month period. To be able to really give good preoperative planning, most patients will undergo a CT scan, also called a CAT scan. And the treatment paradigm or algorithm really has changed over the past 30 years. And so open surgical repair, or an open repair is what we call it, has really been the gold standard ever since it was first performed in the 1950s. This was a very durable, and it still is a very durable option with good long-term results. However, the drawback is that it's a long surgery. Can be extensive blood loss. Anytime you're doing open surgery, you have the risk of concomitant other comorbidities. And so risk factors for a heart attack, renal failure, stroke, and limb loss. Patients can have a prolonged ICU and hospital stay. And of course, each of those comes with the potential for prolonged failure to thrive and decreased long-term quality of life. And so this is what an open repair would look like. We would literally clamp above the aneurysm, we clamp below the aneurysm, we open it up, and we sew in usually a Dacron graft to replace the aneurysm. However, this is really what we want to avoid. I mean, this would not be, I would say, necessarily the standard patient, but certainly would not be unheard of. A patient with multiple drips can be intubated for several days, on dialysis in a worst case scenario. And so this is really where, just like anything in medicine and surgery in particular, if you can have the same outcomes with a less invasive surgery, then that's going to be our goal. And so in 1991, first quote unquote minimally invasive, or we call endovascular aneurysm, was repaired. And so instead of one long incision in the we do this from two smaller incisions in the groins, and we are able to deploy a stent, which a stent is a covered fabric around a nitinol matrix here that was deployed on the inside of the blood vessels. This both allows you to get continued perfusion to the legs, but excluding the aneurysm, so that aneurysm is not continuing to pulsate with every heartbeat. And so our goal here, of course, is to go from this large midline incision to two small incisions, which I one time was criticized by a patient who thought that I really didn't operate on him because he couldn't even see the incisions in his groin. So he did, in fact, though, get an operation. And so the way we are able to do this is by radiology. And so this is me working with several of our residents in our hospital, and where we're doing an fenestrated endovascular aneurysm repair. And we're able to do this by looking with serial images on this screen. And so the steps of an EVAR are, after gaining access here on the picture on the left with the two small incisions, we place two sheaths, one from each side. And this is the picture here where the large sheath is going up. We then deploy that fabric stent, which kind of looks like a quote unquote pair of pants here, and then come from the other side where we can cannulate this limb here and complete the configuration, which on screen right. And so again, with each heartbeat now, that aneurysm is no longer being at risk for rupture, and yet blood flow continues to go to the legs. We're basically relining your aorta. And so the way we do this is by significant preoperative planning. And so this is why a CT scan is important, because I spend many hours beforehand reviewing each patient's anatomy and designing a stent graft, which is specific for that patient. And the things that we look at here are the aorta proximal, or above the aortic aneurysm, below the renal arteries, and that's the arteries that go to the kidney. We look at the diameters of the iliac arteries, where we can deploy that stent graft, and we look at the length. So these are all things that I fill out so that when I'm actually doing the case, it makes for a perfect case without any long-term or immediate complications. And so our goal here, this is a patient that I did just a couple months ago, where she had a very large, you can see this egg kind of sitting in her aorta, and within a couple minutes, she now has two good iliac stents, aortoiliac stents with laminar flow into her legs. And so because of this, we, as the vascular community, have really shifted towards doing more minimally invasive aneurysm repairs. And so this is a study that really just looked at that trend. And so there's a couple of interesting things about this chart. On the left here, the number of EVARs, or endovascular repairs, is in the dark blue. And you can see by the end of the study period, over 83% of cases were treated from a minimally invasive approach. And compared to the trend with the open repair, in the burgundy or burgundy color. The other thing that's interesting here is that as this trend has continued during the years, the actual mortality from open repair has increased. And that is probably a couple reasons. Number one, the more you do of something, the better you are at it. And conversely, the less you do, the more challenging it becomes. And so, unfortunately, most of our residents and trainees are not only seeing endovascular repairs, which is different than what it was during my training time. And then overall, though, the good thing is that the mortality from overall, and especially from an endovascular approach, remains exceedingly low. As I said, though, there are limitations to this endovascular repair, mostly based on the patient's anatomy. And so if a patient has a short normal aorta here, that limits our ability to successfully put a stent graft in. Similarly, if they have very small iliac arteries or aneurysmal iliac arteries, each of these decreases our ability to successfully place a stent from the inside. And the reason here is because if there's different types of what we call endoleaks or leaks into the aorta. And so if I'm put in a stent graft here that there's flow coming around it, well, you've basically not done any good for that patient, because there's still a pulsating heartbeat to that aorta with every pulsation. And so we really have to try to maintain that no type of leak long term to have a successful and durable long-term outcome. And so just like with every technology, initially there were people that we would be pushed to maybe try to encroach on those what we call IFUs, or those limitations. And so we were seeing that patients were having long-term subpar outcomes. And so to get around that, this is how technological advancements have been developed. And so the first one of these was literally a stapling of the proximal endograft. And so you can see here, we've got our renal arteries just above our endograft. And this literally is a device where we do kind of like a belt and suspenders type scenario, and where we tamponade that graft up to the sidewalls. And it's been shown in multiple studies in patients with a maybe subpar or what we call a hostile neck to improve the long-term durability of these stent grafts and prevent long-term leaking. The most, I would say probably the most important or researched technology is what we call a fenestrated Evar. And this has been a technique that has been around for about 10 years. And so the goal here was to improve the long-term outcome and prevent the need for those future procedures. As I said, this was especially designed for patients who had short or really diseased proximal aortas. Each stent in this fenestration is uniquely designed for the patient and is actually created in Australia, of all places. And so what we do here is, instead of just deploying this stent graft below the renal arteries, we actually deploy it well above the renal arteries and some of the mesenteric vessels. Each of these has what is called a fenestration, or a hole in the fabric, again, designed specifically for that patient's anatomy. We then come back and deploy 2 stents into each renal artery, thereby completing the fenestration and allowing for persistent perfusion into the renal arteries and no endoleak into the aorta. And so here's an example of a stent graft that has either a scallop or a true fenestration that would lead to continued blood flow into the renal arteries. And here's another picture, and a picture of us placing 2 wires, and here's 2 covered stents that were about to be deployed into the renal arteries, or the arteries that go to the kidneys. And then here's our main body. And so here's a CT scan from a patient that was, the aneurysm was abutting up into the renal arteries. You can see very close here, and the 1-month follow-up, The stent graft is nice in place. You can still see the aneurysm, but there's no filling, good flow into the renal arteries, and good flow into the iliacs. And so, as I said, the iliac arteries are the blood vessels that are what the aorta bifurcates into. Unfortunately, up to 20% of patients with AAAs can also have iliac artery aneurysms, and that can be an extension of the aorta down into the iliac arteries or even further. However, if you think about it, trying to deploy a stent graft into a vessel like this is not going to have good long-term results. In the past, we often had to create unique configurations to address this issue, and we would do this even when I was in my training, where we would try to put together a combination of, you can see this patient had significant aneurysm in both the aorta as well as the renal arteries, which are these right here. And so what we did was try to modify stent grafts and cut them off, and we had to put 3 in configuration together, one here where we were extending into the iliac arteries, and then a second one up here, such that now the blood flow is going into the legs and the iliacs, but no longer filling the aneurysm. And so that took a lot of time, and we knew that there was a need. We as the vascular community knew that there was a need for better technology. And so to try to extend our treatment lengths, we came in with what is called an iliac branch device. And so this is a specialized stent specifically designed and for the patient, in which there's now a limb that's extending into the iliac artery here. And then through a series of steps, we're able to put covered stents into the iliacs. And then we come in and finally complete with our traditional Evar approach and make a connection here. So now again, all the blood flow is going into the appropriate vessels, and the aneurysms themselves are no longer being perfused. And so, of course, just like I said, with anything, we want to try to treat these patients from a minimally invasive approach. And this goes on, this thought process extends even proximally into what we call the descending thoracic aorta. And so aneurysms can occur not as frequently, but in this area. And this is not located, the descending aorta is not located behind the intestines, but rather behind the lungs, as the aorta is approaching away from the heart in the chest. And so you've got, this was a patient that I treated here that had a large aneurysm here just after the takeoff of the carotid vessels. And so rather than just open surgery, which would require a thoracotomy, which I'll describe what that is in just a second, through one small incision in the groin, we're able to deploy a stent graft, and with significantly better outcomes. And this is that same patient here. You can see this kind of egg sitting on the patient's in the patient's chest, and the completion shot demonstrates good flow distally and no filling of that aneurysm. And here's our post-op CT scan 1 month after, with no evidence of aneurysm filling. And this, of course, is what we're trying to avoid. This is a large, what we call a thoracotomy, or a large incision in the chest wall, long-term chest tubes afterwards, and very significant morbidity, large pulmonary complications, as one can imagine, and really a very significant decrease outcomes and quality of life. And so most recently, we've even been able to extend our treatment zone into the arch. This was a patient that I treated within the last month. And a very interesting, you can kind of see this egg sitting here in the arch. The problem here is that the carotid arteries are very, very close to this aneurysm. And so any stent graft that was going to be placed would cover both this vessel as well as what is called the subclavian and the carotid. And so the way we got around that is through 2 small incisions in the neck. I performed a carotid bypass, and then a carotid to subclavian on the other side bypass. And then I was able to do, here's our initial angiogram. You can see the large saccular nature of the aneurysm. Here is the stent graft with the carotid filling the bypass filling, and good blood flow to the left arm. And the completion shows, and her 1 month CT scan, it's a little bit blurry, but I really wanted to get this for this presentation because I thought it was pretty interesting. Aneurysm sac is right here in the middle screen without any filling whatsoever. Good flow into the left arm and the carotids, and good flow distally. So instead of a large thoracotomy, the patient had a very small incision in her groin and 2 neck incisions. So we've even been able to change the paradigm of treating traumatic aneurysms. So when an aneurysm occurs from trauma, it's usually in this location, the same area that I was talking about, the descending aorta. And most of the time, if you sustain an injury to the aorta, you also have multiple other injuries. And so trying to fix this from a large incision, you can see this large egg sitting here on the within the aneurysm, within the aorta. Rather, this is a patient I treated about 7 or 8 months ago and had multiple other injuries. Just from one 25-minute procedure, we're able to successfully exclude the aneurysm, still good filling to all of the carotids and subclavian arteries, and good runoff. And the outcomes from this have been really great. This was a study recently, basically grading the outcomes from traumatic aneurysms, and the mortality in this patient population went from almost 65% down to 15%. So really, really amazing outcomes. So what are the limitations to this, to an endovascular approach? Well, as I tell all my patients, we don't know how these stent grafts are going to last 20 to 30 years from now. The first one that was ever put in, as I said, was 1991. Certainly our technology now is much better, but they do require long-term surveillance. And so my normal algorithm is to see a patient back at 1 month with a CT scan. If everything looks great, then I usually will see them either at 6 months or 12 months with another CT scan. Hopefully after 1 to 2 years, we can go to an annual ultrasound, which of course is much better for the patient for the reasons talked about earlier. However, up to 15% of patients may need a future procedure. Now, most of those are minimally invasive, either a small angiogram or checking on a small leak. But these are the reasons that patients have to have long-term follow-up. And the studies have shown that there's in the first 2 years after the aneurysm, after an EVAR, the readmissions for aneurysm-related procedures are higher. And this was something that we looked at during my training, and we found that following open surgery, there was a higher return to the hospital and admission for failure to thrive, for cardiac complications, pulmonary complications, and small bowel obstructions. And these are all complications that you would expect from a large open surgery. However, this was at the expense of a higher number of readmissions for device or aneurysm-related complications. And again, most of these are minimally invasive, but it's something that's an important thing to talk to patients about. So the takeaway, I hope, from today is that an aneurysm is a dilation of the blood vessel. It can occur in any artery in the body. However, AAAs are the most common location, and their causes are multiple in nature. Smoking is a significant risk factor. If you smoke, I encourage you to please stop for all the many reasons, but especially because of your risk of aneurysm development and rupture. Larger aneurysms do warrant surgical intervention. I think that vascular surgeons absolutely have embraced technology, and with this have been able to move to minimally invasive approaches. At Santa Barbara Cottage Hospital, our patients definitely can feel comfortable that the skills and training that we have are used to treat aneurysms using minimally invasive techniques with optimal outcomes. So as I said, when I describe myself to patients or to people I meet, I do say that I'm a plumber of the body. And so the other things that we treat are carotid artery disease, most commonly carotid artery stenosis to prevent strokes, peripheral arterial disease for patients with leg pain with walking or with very severe limb threat. We often treat patients for varicose veins or lower extremity swelling. Thoracic outlet syndrome is a complex disease that I treat both surgically and conservatively, and we perform hemodialysis access for patients who require long-term dialysis. Resources, I think the best resource is the Society for Vascular, besides your local vascular surgeon, would be the Society for Vascular Surgery. And here's the website, and they've got patient handouts and easy to remember facts, not only on AAA disease, but on they have a whole patient section, which I think is really, really helpful. So I hope that you all have enjoyed this today. I hope it's been entertaining. I hope you learned something. And I hope that when you think of vascular surgeon, you think of our team. We are always here for you. And I again thank Cottage for the opportunity to present today.
Thank you, Dr. Casey, for that wonderful presentation. We'd now like to open the room for questions. So as a reminder, please put your questions in the Q&A box, and I'll read them off to Dr. Casey, and we'll try to answer as many as possible. So the first question that has come in here, Dr. Casey, is, can deep tissue massage make an aneurysm occur?
So that's a good question. So a deep tissue massage make an aneurysm occur. It certainly cannot make an abdominal aortic aneurysm occur. As I said, aneurysms can occur anywhere in the body, and trauma has been linked to aneurysms elsewhere. I've never, I think maybe one time in my career have I seen, it was a vertebral artery aneurysm that I treated, and the only risk factor was that a patient had a deep tissue massage. And that vertebral artery sits much more superficial than many other blood vessels. So that, I mean, that could be, that was the only risk factor. So that's, so it's not common, but that was the only time that I've ever experienced it as a potential etiology for an aneurysm developing.
Thank you for that. Do you also treat ascending thoracic aneurysms?
So I kind of alluded to this a little bit earlier. The ascending aorta has obviously a very proximal relationship to the heart itself. And so for that reason, that's the one part of the aorta that the cardiothoracic surgeons and their team treat and follow and monitor. And so oftentimes if I'm referred an ascending, which, you know, a lot of people wouldn't know which goes to which, we'll refer that out to our colleagues in the CT surgery realm. If somebody has one and they need a doctor who can follow that, I'm happy to give a referral. So they can just call our office. I'm happy to give a referral. Our CT surgeons at Cottage are top notch.
Awesome. How do you close the stent, and do you attach stent to the aorta?
So great question. So the stent, you don't close the stent. When you deploy it intraoperatively, there are different maneuvers. Some of it's you unsheath it, and then it has a radial force that extends out onto the aortic or iliac, the blood vessel wall. That's the most common. Sometimes you unwind it. So there's different deployment modalities, and that's why we use the radiographic imaging to make sure that I deploy it accurately and in the correct place. It's also important to make sure that my sizing is correct so that I'm not undersizing or oversizing my stent graft. So it's based on your CT scan and your own personal anatomy.
Okay, so then leading up to the next question then, is a CT scan more viable for assessment as opposed to ultrasound? Is
a CT scan more, I'm sorry, Christine, I didn't hear that. Is it more viable? Or is it
more viable for assessment of an ascending aneurysm size over ultrasound?
Good. Okay, so an ultrasound is an absolute perfect screening technique. It's got a sensitivity of, I think, 99%. So I would not recommend routine CT scans. Okay, because I would not recommend CT scans for that reason. A CT scan, it does, of course, give much more detail, right? But at the expense of it's invasive, it's costly, it requires contrast, which can have complications. So we do not recommend routine annual CT scans unless we're following an aneurysm or something along those lines. So first line screening is an ultrasound with truly very good results.
Okay. And then you mentioned genetics could be a factor. So how would this be determined? Is there a genetic test?
No, it's really based just on an interview, family history. You know, do your mom or dad ever have any aneurysms? Certainly, the question is, well, if I'm adopted, how do I know? Unfortunately, there isn't a genetic test and because we don't know if there's one gene or if it's multifactorial. We're still really learning, the answers to that.
Okay. And so if someone has been diagnosed with, I'm not quite sure, AA, and they're about 66, should they be concerned about lifting weights in the gym?
So I think they meant a AAA, right? So an abdominal aortic aneurysm. Should they? No. I mean, moderate exercise, routine exercise. I really want to emphasize to patients that, we want, you can't make, because the patients will say, did I do anything to make this grow faster by lifting or anything like that? No, if you smoked, then the answer is unfortunately, yes, you did. That is a risk factor for aneurysm development, but heavy lifting or moderate exercise, no, all of these are encouraged because that's good for a healthy lifestyle overall.
Perfect. And so then what are some of the signs of having an aneurysm?
Unfortunately, there's very few because where it sits deep in the spine, patients, the aneurysm could grow to be 6 or 7 centimeters without a patient ever knowing. And so that's why that gets to the whole discussion on screening. If you've got risk factors for AAA, a screening test is a very good and non-invasive way to notice. I mean, the implementation of the Medicare policy of routine screening for those patients with risk factors is actually one of the major things that has decreased the morbidity and mortality from aneurysms, because we were catching these patients, because as I said, it's called the silent killer.
And how is an embolism created after an aneurysm?
An embolism, I mean, so an aneurysm, I'm not sure I understand the exact question, but an aneurysm, because so the most common complication is rupture. However, as I said, there are peripheral aneurysms where in what we call the popliteal artery behind the knee and the femoral artery, which is in the groin. Those aneurysms, we don't worry as much about rupture, but when an aneurysm a vessel becomes aneurysmal, it's not having that laminar flow. And so sometimes clot can form within the aneurysm sac. And then that clot, unfortunately, can what we call embolize or shower distally to the leg. And so that those are a little bit different, but those are for more worried about for peripheral artery aneurysms. So I'm not sure if I'm answering the question appropriately, but that's how an embolism can form from an aneurysm.
Okay. This question is, what blood pressure numbers do you like to see if someone has a small aneurysm?
Well, I mean, we want to get as close to a systolic of 120 over a diastolic of 80. I mean, that should be our goal. So you should definitely be working with your primary care doctor on, medical and health and lifestyle modifications to get to that number.
Okay. And then if someone quit smoking about 34 years ago, are they still at risk?
Great question. So the Society for Vascular Surgery defines a history of smoking as a risk factor. Anybody who smoked only 100 cigarettes, which seems that's only 5 packs or 5 packs of cigarettes. So that seems like a really, really small number. But that's what the definition is. So yes, that person probably should be screened, even though they quit 30 years ago. Now, as you could see from that chart that I showed, the risk of aneurysm growth is going to level off, and their risk of it growing continuously is not the same as it is somebody who is currently smoking. But they still would be considered higher risk, even though they quit 30, such a long, long time ago.
And then what is the decision criteria for custom versus a standard stent?
Custom versus standard?
Correct.
Yeah, so it's all based on, everyone is customized, right? Each one, they're different sizes. Yeah, everyone is customized to your own anatomy. That decision is made by me and those pictures that I showed of what I have to do in the preoperative area. Now, when we're talking about more specialized, customized, these are all based on decisions that I make from looking at the CT scan, looking at the anatomy, whether it's the aorta diameter, whether it's the size of the iliac vessels, et cetera. So these are all things that are thoroughly looked at after I see the patient in clinic, and then I have the opportunity to review the CT scan and draw it out.
Okay, perfect. And for this one, it's a scenario, if they're a 65-year-old male who has a descending aneurysm, it was noted to be mild. If they're controlling their blood pressure and cholesterol with the assistance of medication, are they at low risk? There's no family history.
Well, I kind of have to know numbers. If it's a very small aneurysm, then the risk is very low. Once it gets closer to 5.5, similarly to the abdominal aorta, that's when we, seriously consider intervention. I would absolutely recommend tight blood pressure control, as we said. I think that patient also would probably benefit from a baby aspirin implementation from a baby aspirin as well.
And then could this be detected during a procedure such as like TAVR?
So a good question. It could, yes. It could. Sometimes they can see that the aneurysm exists. An angiogram or an aortogram in general is not the best screening technique for different reasons, but certainly it absolutely can. I wouldn't say that you can rule out an aneurysm because one was not seen during a TAVR, if that makes sense. So it's not a good screening technique, but can be picked up during a TAVR.
Got it. Okay. And then during an open surgery, do you wrap the aneurysm or is it cut out?
Great question. No, we actually clamp above and below. We incise the aneurysm. We basically kind of fillet it open and then sew that graft in an end-to-end fashion to the proximal aorta and then to the healthy either distal aorta or iliac arteries beyond that.
And then let's see here. And in respect to statins, is there one that is better than others? And if so, is there a dosage that is best?
Oh, yeah. No, that's a good question. So the advantage of the statins is the anti-inflammatory aspect of them. So oftentimes, we'll have patients say, well, my cholesterol numbers are good. Do I still need to be on a statin? It actually doesn't have to do from aneurysm growth perspective. It doesn't have to do with, the cholesterol. It has to do with the anti-inflammatory. So I recommend starting on a low dose statin because I think that's the most beneficial. The main side effects from statins, the main one is a lot of people complain of muscle aches or muscle pains, can even get myositis. You can also get elevated liver enzymes. Usually it's not a long-term problem, but it's something that does require monitoring with routine labs, and why often we initiate this medication with your primary care doctor. I don't think that there's a significant difference between Lipitor, Crestor, Simvastatin. I will say that for patients who don't tolerate one, my recommendation is to either, if they're not on the lowest dose, start with the lowest dose. If they are on the lowest dose, consider trying a different one, because sometimes patients, even though it's the same class of drugs, for whatever reason, they'll get muscle aches with one, but tolerate the other one just fine.
Okay, perfect. So we have time for one more question, and it's another question scenario. So my brother has an aneurysm, but I do not. We do have a family history, but he's also a smoker, and his AAA measure is about 4.2. It has grown slightly over the past several years. If he quits smoking, will that also decrease the size of his aneurysm?
So, no, the short answer is that's not going to decrease the size, right? But our goal here is that it levels it off. And so that trajectory, unfortunately, and not, I mean, we talk in like larger scale values, but in general, the trajectory of an aneurysm, if you continue to smoke, is going to, the size is going to continue to increase. And hopefully by stopping smoking, that's going to level off. At 4.2 centimeters, the chance, as we talked about, the chance of rupture is exceedingly low. And so it's never going to, you can't talk about it in terms of a normal getting back to zero, but our whole goal here is to stabilize that growth and that you never have to have that operated on.
Okay, great. Thank you so much for all of that great information, Dr. Casey. That concludes our Q&A period. Thank you everyone for your questions, and thank you for joining us this afternoon. Dr. Casey is located in the Santa Barbara Vascular Specialist Office at 2621 Della Vina Street. If you have further questions or would like more information, please call his office at 805-456-8890. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. Thanks again for joining, and have a happy and healthy rest of your day.